Good afternoon. It is my pleasure to welcome you to our town hall hosted by Black Creek Community Health Center and Humber River Hospital. I am Barb Collins, the President and CEO of Humber River Hospital. Each February, we reflect on how members of the African, Caribbean, and Black communities have contributed to our culture, our politics, economy, and society. Today's event is to honor Black History Month by delving into a topic that is of relevance to this moment in time, the fight against COVID-19 and vaccination of our community. COVID has shone a spotlight on the inequities in our society. Toronto Public Health reports that Black people account for 24% of the reported cases of COVID-19 in Toronto, while making up only 9% of the overall population. Northwest Toronto is home to the second largest Black community in Toronto. We have heard that the history of racism in healthcare, medical research, and effects of society's economic conditions that cause a higher percentage of pre-existing health conditions are but a few of the reasons why members of the African, Caribbean, and Black communities are cautious about the COVID vaccine. We hope that today's conversation is a continuation of many that are being held across the city of Toronto to address concerns in these communities, to educate many of us so that we can collaborate on strategies that will meet the unique needs of the African, Caribbean, and Black communities. We have brought together a great session today to address these issues. Without further delay, let me welcome and introduce our moderator and our panelists. Our moderator today is Anna Greenberg. Anna is currently the Interim Executive Lead, Clinical Institutes and Quality Program at Ontario Health. Her current portfolio encompasses several provincial clinical programs within Ontario Health to advance clinical excellence and quality on behalf of patients in Ontario. Anna also oversees provincial quality programs to reduce variation in patient care, to promote health equity, inclusivity, diversity, and anti-racism. She makes evidence-based recommendations to Ontario Health on whether publicly funded new technologies, health technologies, monitors and reports on health system performance, and supports continuous and targeted improvement in quality. Effective March 1st, Anna will be assuming the role of Chief Strategy and Planning at Ontario Health. In this role, Anna will be leading Ontario Health's equity and diversity portfolio and specifically leading the work on creating the Black Health Plan. Welcome, Anna. We have three panelists with us today. And the first panelist I want to introduce you to is Adaoma Patterson. She is currently Manager of Poverty Reduction and Community Engagement in the Human Services Department at the Regent Peel. Adaoma completed her Bachelor of Arts at the University of Windsor and has more than 25 years progressive experience in the not-for-profit and public sector. Since 2016, Adaoma has been the president of the Jamaican Canadian Association, known as JCA, a 58-year-old organization serving the Jamaican, Caribbean, and African Canadian communities in the GTA. As part of her current mandate, she's focused on increasing the involvement of youth and young adults in all aspects of the organization, building new partnerships, ensuring the sustainability of the organization and the JCA Center located in North York. Welcome, Adaoma. I'll now introduce you to Cheryl Prescott. Cheryl is the Executive Director at Black Creek Community Health Center and a partner with Humber River in the Northwest Toronto, Ontario Health Team. She's a dedicated community leader for over 25 years. She's a coalition builder, bringing together diverse stakeholders in community development initiatives that reflect the needs of the people in our community. Cheryl facilitates numerous community academic partnerships in research to build evidence that informs policy and innovative approaches to complex problems in our marginalized communities. Cheryl has an academic background in biochemistry, with a graduate degree from the University of Ottawa and Toronto, and many leadership training in healthcare and nonprofit management courses from the Rotman School of Business, the Schulich School of Business, and the Harvard School of Business. And finally, I want to introduce you to Matthieu Kamwa. Matthieu is a senior global health consultant with the World Health Organization. Dr. Kamwa holds a Doctor of Medicine degree, a World Health Organization certificate in epidemiology, and a postgraduate degree in public and community health. Some of his recent affiliations and some of the knowledge he'll bring to the table today comes from being a senior advisor, COVID-19, World Health Organization, Regional Office for Africa, an adjunct professor at the Faculty of Health for York University in Toronto, past co-chair of the Board of Directors of the AIDS Committee, York Region, Board and Board Treasurer of the Canadian Coalition for Global Health Research, a global health mentor for the World Health Organization, and a mentor for Canadian Public Health Associations. Dr. Kamwa has over 40 years of leadership in communicable diseases, disease control, introduction of new vaccines, planning and implementation of mass immunization campaigns for such diseases as polio, measles, meningitis, and yellow fever, and oversight of the health policy and strategy development, healthcare system reform, and restructuring and management of health services and programs. So I welcome all of you to the table today, and we will allow the session to begin. Thank you.
Thank you.
Excellent. Thank you so much, Barb. And I want to say thank you to the Humber River team for inviting me to moderate. It's a privilege to moderate on this topic and during Black History Month. So just a few of the basics before we begin our session. We're going to ask you, the audience, to answer 3 polling questions during the session. And the polling questions are going to be in the spot below your streaming video. So we'll give you a sense when those come up, but just so you're ready. We're also obviously going to hear from each of our speakers throughout the session, and they're going to reflect on your polling responses, and they'll also answer some questions that I will pose for them. And then we're going to open it up to you again for a Q&A from the audience. I just want to remind you to please enter your questions in the Q&A box, and then we'll address each of these during the session. If we can we won't necessarily get to all of them, but we'll try to get to most of them. And type your question in the spot, again, provided below the streaming video. The chat feature is also available, but we'd like to have questions go through the Q&A box so that we can organize that a little bit easier. Okay, so it's time for our first question poll. And we're going to ask you to take that poll, and that should be visible to you now. And the question is, if offered the vaccine, will you take the vaccine?
And I'm going to read the results of the poll to you. Looks like of the participants, we have about 51% who would agree to take the vaccine, about 13% who would not be willing to take the vaccine, and then about 20% in between. So a high proportion willing to take the vaccine, but a minority, about 14% that would not take the vaccine if it were offered.
Excellent. Thank you, Sudha. So I think we can see, we can motivate our panel on how we can help to have this conversation, given the starting point for our audience members. And what I'd like to do now is ask Cheryl in particular to reflect on these poll results here. And in reflecting on that, tell us, in your leadership capacity, what role you've been playing in the COVID response, and what do you see as your role in the vaccine rollout?
Thank you, Anna. And thank you, Barb and team at Humber River, for the opportunity to partner with you in this important session. It's not only because it's Black History Month that we must have this conversation, but it really is about the health of our community, those that we serve. And I know that we are all committed to doing this in partnership. And this past year, with dealing with COVID, has been difficult for all of us, for healthcare workers, for the community residents. And I just hope that we can continue working together as we address this. Now, to answer Anna's question around the results, this is something I'm not surprised by that, the results we've seen. We've seen similar numbers within the community as we did informal polls, and it's also reflective of other statistics, other numbers we've seen across different parts of the world, actually within communities, especially diverse communities with a large number of African, Canadian, Caribbean residents. Now, we knew that when COVID hit the world, and in particular this community, we knew that because of what we saw as the risk factors for transmission of the virus, that the Northwest Toronto community would be hard hit, simply because We have a densely populated community. We have many folks who work in essential front-facing services who are going to work every day to ensure that the rest of us are comfortable. They're in front. They're in the grocery stores. They're in the factories. They're in the distribution sites, and they're traveling on crowded transit systems. Unfortunately, many of them are in precarious jobs that are not without paid sick days. So some are most likely going to work sick. All of the things that we're told not to do. So it's unfortunate, and I don't want the results that we're seeing and the high positivity rates in our community to be a negative reflection on the people who live in the community. This is an amazing community with people who are hardworking. However, there's some structural issues that prevent them from living in a better circumstance. So as a result, they also have some high prevalence of chronic conditions that, again, make them much more amenable to hospitalization when they are infected with the virus, many with fatalities. And this is something that's heartbreaking for all of us who live and who work in this community. So from the moment that the pandemic was declared, community organizations, community healthcare providers, the hospital, our partners came together, and we developed mobile testing in our community to complement the testing that was at the assessment centers led by Humber River Hospital. We've been working with our partners such as churches, recreation centers, community housing buildings, shopping malls, to ensure that testing was brought close to those who needed it so that they did not have to miss time up from work to get tested. We knew the importance of that for all of us. We offered wraparound supports to families, and we engaged community residents in our strategy to do outreach in the neighborhood. They're called community ambassadors, but they were our boots on the ground who were distributing PPE to their neighbors. They were learning about the evolution of the virus so that they can support knowledge translation in the community. And as a community health center, we facilitated this, but the community did the work. And now, as with the vaccine rollout, I see us playing a similar role. I see us working with our community, listening to our community so that they can inform us as to what we need to do to support them and to support the uptake of the vaccine, because we know that the vaccine will save lives. We know that we're all the same when it comes to protecting ourselves and our loved ones. And I think the messaging is to our community is, what do you need from us as your healthcare providers to ensure that you have access, you have equal and equitable access to the vaccine, and you have the information that you need to make the right decisions. That's our job, and that's what I hope that we can continue to do, again, in partnership with all of our OHP, our Ontario Health Team partners, with the hospital, and with the community. The community is an integral part of this, and we will support that effort as best we can. I think that I'll end there and continue with other remarks later.
Thank you so much, Cheryl. And I think also congratulations, I think, on all of the work, the tireless work you've done with partners to co-design these interventions with the community. And I think it actually bears out in the data where we saw a very, very wide gap in the summer. And we're still not anywhere near the equity that we'd like to see, but we've certainly seen a narrowing of that gap due to the work of people like you and the partners that you've worked with, Cheryl. I do want to ask our other panelists if they want to weigh in at this point on the results before we get to the rest of the session.
Yeah, I would be pleased to make a few comments.
Please go ahead, Dr. Kamwa.
Yes, thank you, Madam Chair. Thank you, Shirley, for this the introduction, but by itself is more than an introduction. So, and in line with what you have said, I would like to remind all of us that immunization, for instance, is a key component of primary health care. And beyond that is an important human right. We don't consider vaccination or immunization as, some parts of healthcare. Healthcare is beyond. It goes beyond that, and the history, tells us that it was not easy for many communities around the world. Starting with the African and Caribbean community. The access to immunization has been, very difficult journey. So, at the level of communities in general, one key message is community empowerment. Because over time, we do it. I say the community, the healthcare community in general is a bit, I would say, a bit tight about the relationship with community. So I'm happy that Cheryl also insisted on that. Relationship, which is not only built but which is strengthened over time. Another key component is, how do we really sit together as partners and listen to communities? Worldwide is a component which is still missing. So we need to jointly define communication lines and roles. But I would say globally is less than, less than 10-15% of communities which are involved in that way. We in general, the health services come in with, I would say, their Bible, and so okay, this is the way that's what to do, the way to do it, and to get this or that. I think if there is a platform which is well established and through which those two groups can come together, work together, reflect together, because communities per se have, wherever they are, they have the important role to play. I would say multiple roles to play. And this will also help us, since one of the agenda of the day is to really fight against vaccine hesitancy. Communities many don't join us because, they are not part, they don't consider themselves to be part of the game at the beginning. They are just consumers or so. So I will stop at this level. Back to you.
Thank you very much. And I think the theme you've both talked about is listening to our community partners in how we want to design these public health interventions. I'm going to turn to Adaoma now. We heard through Suda's reporting of the results that we had 13% of our audience who say they're unwilling today, 51% would be willing, and the remainder being on the fence. And I would say, maybe help us understand how history and other factors may be influencing African, Caribbean, and Black communities' decision-making related to vaccine, despite what we may know in the science.
Right, thank you so much. And thank you for including the Jamaican Canadian Association in this. We have worked with Cheryl and Black Creek in trying to communicate the message to our, who we call the JCA family, and that includes seniors, children, and adults. I think COVID has really taught us or reminded us that history matters. And so many of the things that we are talking about and we've spoken about since the pandemic began last year is really influenced by our experiences historically. And so whether that's here in Canada, in the US, the UK, or in what many of us refer to as home countries. And there is a long-standing history of exploitation, mistrust, feeling ignored by the healthcare system for a variety of reasons. And so now when we're asking people to come forward and believe in something that was developed, many say that they're concerned about how quickly the vaccine was developed. We're asking people to sort of step out in faith and trust this healthcare system that often, when they go, whether it's their primary care physician or emergency, they have negative experiences. For a variety of reasons. And so that's obviously where you see the 20% that are not sure and the 13% that are saying no. That we have to, as healthcare providers and the systems, especially leaders within the system, have to acknowledge that those long-standing experiences, whether you're talking about things like hysterectomies or pain, just not being believed when you go in and you say that something's wrong and you're being dismissed, that it is going to impact other things. And until we acknowledge that, I think openly, and continue the push for disaggregated data, right? That's part of the invisibility that has happened over many, many decades, is that really in Canada, we have not been good at disaggregating the data, understanding what those experiences are. And so advocates who've been knocking on the door and saying, hi guys, there is a problem, are now, of course, being proven right. And so all of that's contributing to people's hesitancy around whether they should take the vaccine. I actually spoke to two people recently, one in healthcare, a Black woman who, works for her. She's a consultant in healthcare, and she's not sure. She's among, that the 20% of people who are viewing today who say, I really don't know. How does it really do what they say it's going to do? What about the variants? I don't like going to the doctor. I have to fight and advocate for myself and my children, and then I spoke to a senior who was in that 13% no camp. And again, it's about the experiences that she has had over her life course that she's been in Canada, with walk-in clinics and her primary care physician, and just other negative experiences for her family. So, all of that again to say that until we address that elephant in the room, it is going to be difficult for people to fully trust what they're taking.
Thank you very much. Can I ask a follow-up question on that, which is, and I'm thinking about all three panelists, but what are some of the ways that you think, you talked about listening, you've talked about understanding the community, but how can we, as we think about the vaccine supply, hopefully coming soon and being plentiful in Ontario, what are some of the ways that we can partner with communities to make sure that no community is left behind? And to address what has been a disparity, but I think we have a significant opportunity to actually narrow a gap with the vaccine coming into Canada.
So I think one of the things that I have found, even in my conversations in the last couple of weeks with people, and I think Cheryl, spoke to it, is I will be taking the vaccine. And so who are those community champions? Who are the people who connect, whether through formal organizations or the ambassadors that Cheryl uses at Black Creek, people, residents who can speak to it and at least direct people on where to go. I think that without that partnership, faith community, I heard Cheryl talk about, churches, are a key influencer. Faith organizations are a key influencer in our community. And so without sort of going hand in hand and being transparent and just being open and acknowledging, again, as the healthcare system, you know what, we didn't hear you before. We understand it now, and we can help to reinforce those messages.
Great. Thanks very much.
Yeah.
Cheryl, it looks like you might have something to add.
Yeah, I would like to. Yes, I mean, I would like to again add a few words on to that. I mean, the message is very well articulated. But if we go back to the history, we'll notice that vaccine hesitancy, at least for the group we are talking about today, is due to discrimination at the beginning, because vaccine was meant for a few, not for everyone. And over time, of course, people say, why should I now be given vaccine? Why should I even now be thinking about getting my kids or other members of my family to get vaccine? So it's really I would say, very difficult task for the health, I would say, health community to go back and address this in one single, one single year. It's a very long process. Unfortunately, in some countries, whether rich or poor, vaccination is not, or immunization is not considered to be, a key component of healthcare. So, if we take COVID-19 as today, of course, it's only last year. Last year we started. I mean, let's say we started, all of us, because we heard about it. But the vaccine, or I would say the vaccines, because we have at least 3 or 4, even 5 today, which are available. As you notice everywhere, or you have read, that the name of even a poor country is not commonly on the table. So they are talking about rich countries. And WHO has to really work hard with some other partners, the pressure groups, to say, no, we can't be talking about vaccination without thinking about, in fact, the majority of people on health. So now, some who have the luck to be rich, so they say, okay, we have to make sure that our own community, our own people are fully vaccinated. Then we'll see. We'll look after you, which is really, again, I would say, a big blow to the principle of healthcare, which is a right. It's not, something you can say, okay, this group will have access to it, and the other, nothing at all. So we just hope that, communities will take, I would say, possession of the idea of, this is our right, we deserve it as well. But the dilemma, and this has been said a while ago, is that, okay, community members themselves, given the history, are reluctant to accept even when vaccine is made available. That's the struggle we'll have over the coming days, weeks, even months, to make sure that, okay, people are really sensitized. They are there to the principle. They understand that it's for their interest, no matter what, and we'll take it from there. But we should not think that it will be done overnight. It will be done that fast. I don't think so, based on experience in different, even different continents. It's the same tendency, and it will take time for some of us to accept, okay, this is the right thing. Of course, this is the right solution to COVID-19. It's not, there's no other thing better than the vaccine. But we are paying the price of some, I would say, mistakes in quote in our history. Back to you.
Thanks very much. So agree, this is not about a messaging or a communication strategy, it's about trust. And I think Adaoma highlighted some of the ways in which we can leverage leaders who are already there, where there is already trust and relationships built up. I wanted to ask Cheryl, anything to add on things we can do with community to leverage trust where there is?
I think we saw this from the time we started testing in the community. There was really a reluctance to testing in general, again, because of that mistrust, not necessarily of the testing methodology, but just about the process and the mistrust in our system, unfortunately. And again, as Dr. Kamwa said, this trust will not be built overnight. This is work that we continuously have to do. I've seen the change in the community members. I've seen higher uptake of testing. And similarly with, again, working with our community ambassadors who are telling us, who are their gold mine of intelligence and of understanding of the community and what they're hearing in their buildings, in their churches, in their mosques, in their temples. They're telling us what we need to do. And one of the things that we actually advocated for and were successful this past weekend is we ensured that some of these community ambassadors, members of the community who live and walk the streets of the community, they got access to the vaccine. And already they're telling me that their neighbors and their friends and family members who were absolutely 100% against it a month ago, 2 weeks ago, are now saying, well, if you did it, I trust you. I trust that this is not a bad thing. So again, it's who do we trust? They may not necessarily trust me or someone else, but they do trust their neighbors. They trust their primary care providers in the community. So again, we as healthcare providers within our system, we have to think of ways that we can work together to engage different kinds of partners in sending the messaging of the importance of taking the vaccine and protecting themselves. So again, it really are those folks on the ground who are helping us with that messaging.
Terrific. Thanks so much. So we are going to go to our next poll, and just thinking about the concerns that you have about the vaccine. It's going to help our conversation, our panelists, to address some of these issues. So if you can take the next poll, it'll again be under the streaming video, and then we'll see what the results are and have the panelists respond.
Okay, the poll has been launched, Anna, and just looking at the results. And for people that haven't completed the poll, please complete the poll. Right now, as the results are coming through, it looks like about 22% of people have concerns around the pace of the vaccine development, with smaller numbers concerned about lack of trust in the healthcare system, lack of trust in government, lack of trust in pharma, and again, a small percentage who believe in their natural immunity. So about 23%, the highest number, are concerned of the pace of vaccine development.
Thank you, Suda. And very, very important, I think, to understand that there's variation in what concerns may be. There's variation in communities. We've already talked about the history. So what I'd like to do now is ask panelists to comment on this. And I'm going to start with Dr. Kamwa. in particular this issue about vaccine development and the pace of it, and what you can tell us about that pace that might help to ease the concern about that.
May I start?
Please do.
Thank you. I mean, I'm pleased to hear the comments. I mean, let's say the comments made by the target population, which, I mean, those comments are in line with what alluded to earlier. But with regard to, I would say, the development cycle, because it will be too long for us to go through all the, from the, I would say, the beginning to the end. I will just focus on 3 important steps when it comes to vaccine development. One, we call it exploratory stage. This is done purely in labs. So I mean, there are only a handful of people who are in the knowledge that okay, this or that is being done. I'm referring to scientists who will do that work, and they do it with not with human beings, so they do it with animals, or they do it with other. When it comes to virus, they do it with other viruses. As we speak, and in relation to the COVID-19, we have about 200 teams working for the development of vaccines. So, I mean, it's also competitive, as we know. Is if you have that capacity, whoever has that capacity will do it now, because it's a big income generating business. So they do it for human beings, but they do it also for business. So this is done, as I put it earlier, I mean in the lab, so we don't know unless you are familiar with the matter. So it's under control by the technical teams. The second stage is what we call preclinical, meaning that again is still in the lab, but they are doing it with some the so-called lab animals. It's a wide range. It can be mice. It can be other small animals which are, kept in the lab. They use them to test not the quality, but the potential of the potential in quote of the vaccine being tested. So it takes some time, depending on the size of the team. They can come up with in a longer or short period of time that okay, this vaccine is or vaccine candidate, as we put it, is good, is convenient. So we can now request the passage to human beings. And we will enter the third stage with at least 3 phases. Last stage is what we call it the clinical stage. So, of course, for many vaccines, candidates don't reach that stage. So the first phase is to use volunteers. So we don't force, and nobody is forced in. So you choose. Okay, we have this vaccine candidate, we are recruiting volunteers. If they are willing to join, they will be on board. And it is just to, I mean, this stage is meant for two important parameters. One is the safety. Is it safe? The product is safe. That's one. And also the response. How are the bodies or the person, how are they going to react to the vaccine? Even if the vaccine is, I would say, is safe. Are they going to generate antibodies, which are the elements we will protect, or not? And if they do, what would be the level? Then the second phase is now we expand the number of participants, and this will allow the system or allow us to know, okay, what are the, I would say, the range of risk deriving from the use of this or that vaccine. And the last is phase 3, giving to thousands of people at the same time. And now they have to start comparing groups, maybe gender-based, this age group, this group based on the age and the age, and also at times the color of skin, because some vaccines react differently depending on the color of skin. And I will stop my comments at this stage if there are questions, because it's a bit too technical, but I will stop at this stage. So, but if there are questions, I can provide clarification. Thank you, Madam Chair.
Thank you very much, Dr. Kamwa. And I do want to remind people that they can put questions in the Q&A box, and we have received some good ones so far. So please do send in your questions. But just to say thank you to Dr. Kamwa for that, I think very helpful to understand that a lot of the science and technology about these vaccines actually didn't start with COVID-19, but actually preceded this pandemic. And so there was a lot of science and technology underway. Very important to understand that all of the steps in very rigorous trials, no step was skipped, although we did have speed because of the global pandemic and many collaborators around the world, all searching for the same question. And having, as Dr. Kamwa mentioned, tens of thousands of volunteers who by the time it was clinical, after the preclinical phase, had signed up. And of course, safety and efficacy are checked at every step. And then I think important also to note that there are certain groups who are having trials now, like kids, who weren't necessarily in the original trials, but they won't be approved for kids until we've gone through those very rigorous steps, just as an example. I did want to give the other panelists a chance if you wanted to comment on the results before I go to the next question. Not mandatory, but if there's anything else you wanted to add before we move on to the next question.
I think just quickly, again, I think the part of the struggle that folks have is, that prior to the pandemic, many of the things that we were talking about, obviously outside of COVID, but the inequities, working poor, conditions, wages, sick benefits, dealing with diseases that impact Black people disproportionately. We were always sort of told there's a process and you have to wait and change takes time. And then during the pandemic, we saw immediately governments were able to respond, shift resources, invest in things quickly. And so just to the point on the poll question about, again, the lack of trust in the healthcare system or government, people have said, obviously, if government wants to make something a priority, it can. And we figured out lots of ways to support people in ways that we hadn't prior to that. And so I think, these things sort of compound to add to that reluctance, that hesitancy. And I think people are watching. So while the vaccine, of course, is the thing that's foremost on everyone's mind, it's also, what are the experiences? Like how are your experiences changing with the healthcare system? People have other things. I have an aunt going through chemo right now, and so there are lots of compounding illnesses. And I just think that we have to, again, keep those things in mind. And when we're thinking about shifting resources and the way we do addressing the racism, the systemic discrimination within healthcare, that people are watching, just like people are watching to see how the vaccine will impact people. So if people will say, you know what, I'll wait until the end of the year because I want to see, and I want to see the data, and I want to see those that have said they took it. I want to see whether there are any side effects. It's similarly that they're also waiting just to see what are some concrete steps overall that the healthcare system will take to make some changes that they've been talking about.
Thanks so much.
If I
I
could-
think, oh, sorry, please go ahead.
I just wanted to jump in to just add a bit. I heard a story just yesterday from my relatives in New York City, where I think it really underlies the mistrust in communities, especially communities with many low-income, racialized individuals that have been denied access for quite some time to quality care. Many of them believe. So, and historically, this does come from what, especially in the Black community, what they know of studies that have been done. The Tuskegee study that was led by a public health organization, where Black men, were denied care. So what folks don't understand, I believe, or they don't believe, is that even though those studies were atrocious, they did lead to some changes in policies. And now, we cannot do research and we cannot do so much without consent and ethical frameworks being in place. So I think the conversation is not so much about, the trust in the vaccine itself, the science of the vaccine. It really is about the trust in the systems. Will they really protect us, or will they continue to harm us? So the story is that in New York City, there's a mass vaccination happening for low-income communities at Yankee Stadium. And many people are saying, I'm not going there because they will not be giving me the same vaccine as they're giving others in their doctor's offices and other places. So to me, that really just, it just, again, amplifies that thinking that people do not trust the system. They believe that they will not get the same vaccine and they will be harmed. So I do think it's in our conversation and in our rollout planning, how do we try our best to not give people that to have them think that way, that they can trust us. What can we do to build the trust?
Yeah, and I think,
I
Cheryl,
would
you
like to add
highlighted.
just a word on that. And I mean, just in line with the same. And in many countries in Africa, in the Caribbean region, people, I mean, based on the work I was doing at with WHO, is people go even further by saying that, okay, you are advising us, first of all, you advise us to live in in a confined manner. Maybe you are so ignorant that you don't know that we are already confined. We are already confined because I have I have my parents, my grandparents, my this or that, my aunts. We live in the same I wouldn't say house in quote, and nothing. You are not doing any change to our daily life. And in line with what Sherita said, which is, the message is very strong, very well articulated, but it's almost everywhere on earth. So if you go to, you take the European continent, you'll be surprised by the number of hesitants. There are many. They have more than we do. So, and again, that's where the system is paying the price of discriminatory practices over years, I would say centuries, almost centuries.
It's a big responsibility for those of us who want to reach these communities, make sure that we don't leave anybody behind. I think to heed your words that this is not about flash in the pan, let's build trust. It really is about the ability to reduce an inequity and leverage trust that does exist. But also, what I really liked about what Cheryl said and what all of you have said is actually saying out loud what the history has been and acknowledging what the history has been. And I think really important, tying the link that you did, Cheryl, between the Tuskegee experiment and that kind of a situation and the rigor that we see today in trials and research ethics boards that is absolutely due to that complete disrespect and lack of trust that was completely justified in those situations. I think what I'd like to do is turn to the last question, and then I gather that we have some good questions coming in from the audience that we can field. So the last question is, of course, and I think you said this, Cheryl, this is not just about the vaccine when we think about trust in the healthcare system, but even beyond that, the vaccine is not necessarily the overriding concern of the communities that we're trying to reach and we're trying to serve here. And I think it's important when we think about bringing the vaccine and making it accessible to also understand what other urgent needs we may be, that communities may be facing and dealing with that can influence and inform how we reach these communities. So I wonder if panelists can just give some thought to what other urgent needs we need to be very cognizant of in the communities that we're trying to serve, and that the vaccine is just one component of that. Can I start with Adaoma?
Sure. So, the intersection of these issues, it's an important question because, again, prior to COVID, we were struggling with food insecurity and poverty, significant homelessness, looking at the social determinants of health, people struggling and on the margins. And I remember a report, I think it was the Canadian Medical Association many years ago, that talked about poverty makes you sick because it keeps you in a place that's quite stressful and you're always looking to fill a gap. So it's as I mentioned earlier, I think it's really important now that we have shown that governments can be responsive and the healthcare system and other systems can be responsive to the issues and challenges, the systemic things that are keeping people behind, that we move that momentum and continue that momentum forward to really address the root causes. Because otherwise we'll find ourselves back in, the situation a number of years from now when it's another virus or, something else that comes up and we're again having the same conversation, right? So let's look at those core issues of income, employment, which is going to be a big thing as we come out of, post-COVID, when we look at the unemployment rates for young people, which were stressful and worrisome before, prior to COVID, we're seeing that those numbers are doubling. And in some cases, for some communities, like the Black community, probably significantly higher. So how do we make sure we are making the changes we need to, using this moment so we don't go back to what we had before.
Thanks so much.
Okay. That's Madam Chair. Yeah, I think it's a good,
Go
it's
ahead.
a very good point. But if we don't have to go back to, I would say, to the beginning. When I say the beginning is that, okay, healthcare should be at the last stage. I think it's a package. If there is any message, a strong message, we need a package. We need all of at the same time. So you don't say, okay, you start with this, we will never be there. That's why, I mean, almost 40 years ago, during the Alma Ata conference on primary health, which was, I mean, the first time countries were coming together to say, okay, let us revisit the healthcare system or approaches. And the top recommendation is that healthcare is a right. It's not it's not something people have to be begging to have access to. So it should be made available, and each country should, or each government should make sure that the access to healthcare is not only established but also sustained, so that we don't have that kind of dilemma in many countries, including the richest. We still have people who are struggling between, okay, maybe buying food or buying medication. Today, I'm talking about today. So it means clearly that if there is any message, I mean, I mean, based on my experience, is that we have to struggle for or fight for the package, not one after another. When we choose that way, of course, we'll be living or living behind for years, for if not for centuries, because the government, whatever the government can be, they will say, okay, this is what we can have. That's what you need now. You request, your request is only for 1, 2, not 3. So the third one I'm not giving, because you focus or your priorities on 2. So it's really risky. So I think that it's good to use the so-called comprehensive approach. We need all of those items. No single one should be left behind. Children have to go to school. We can't say you have to take the vaccine before going to school and vice versa. No, all of them. So, and as a community, as human beings, all those elements are part of, I would say, the rights package. So it shouldn't be, a favor by the government. If I think if that approach is considered, I mean, can be considered implemented, I think the benefit will be, will come, I'll say, much earlier than what many countries are going through. And some have even signed that, or they do accept that, okay, these are health, education, this or that. These are human rights. So I don't have to discriminate. So what the package should be delivered at the same time. But unfortunately, it's not happening, even in the richest country. Back to you.
Yeah.
Thank you.
Thank you. And I think that's Cheryl had described in just the testing strategy, all the ways in which people's different needs had to be brought together and thought about to make sure that that people could get accessibility to testing in a way that met their needs. Anything you wanted to add at this point, Cheryl, before we go to audience questions?
Yes, I would like to add, again, given this is a Black History Month session, and it is Black History Month, we're just finishing it up. I think we will all agree that, the racism plays a big role in this. And what the pandemic has done is really highlighted, the pervasiveness of racism in our society. And much of that, especially when it comes to people of African, Caribbean, Black descent, it's linked to socioeconomics as well. And in the community that we're speaking of, that we serve in Northwest Toronto, we have a high number of people in this category. And we didn't need, many of these people know, and myself included, know that we didn't need the George Floyd murder in the US to show us how traumatic and how brutal the system of racism is and its impact. So, for us, racism is also a global pandemic. So we've been living through this double pandemic throughout this time. And as a society and as systems, government, we have to really think about the long-term impact and how we can continue to commit the way we have been committing to overcoming this pandemic. How do we overcome racism? How do we dismantle this system that leaves so many people behind, and many people suffering from the impact of this disease, not only medically, clinically, but also in terms of job losses and all the other social determinants of health. People should not have to be. We should not have such a high prevalence of chronic diseases among this population. Again, because they don't have access to food, they don't have access to proper living conditions, or decent jobs. So I think the vaccine itself, it's great, it's here, and it will help stop the spread of the disease. But unless we address some of these other issues, we will not overcome a lot of the problems we have. And there will be another pandemic down the road that we also have to be prepared for.
Thank you, Cheryl. And I think it was not new to anybody on this panel going into the pandemic, the link between racism and public health and chronic disease and patient outcomes. But I think for the broader society, it actually is the fact that we're hearing that more in the mainstream, I think is helpful as we come out of this pandemic to think about recovery and the ways in which we need to bring those learnings, in addition to what you've all addressed about the other needs of communities that need to be wrapped around the healthcare interventions that we'd like to see our communities receive. I think what I'd like to do now is turn to the audience questions and get your responses to those.
Great. Thanks, Anna. Well, I'll read out the questions and I'll leave it with you to direct them. So the first question is, was SARS controlled with a vaccine?
Who would like to take that? Dr. Kamwa?
Thank you. I think it's a good question. Those who are familiar with or who were interested at that time, SARS was not a pandemic disease, luckily. So it was localized, and the implementation of hygiene and healthcare measures, I would say, brought down the transmission. That's one. Number two, and I remember I was the head of a WHO office in the biggest country in Africa, coincidentally, we had a medication. But that's just a lab, I would say, incident or accident, not in that country, but elsewhere, where we noticed that a medication used to treat patients who are affected by a disease, making them, I would say, in a short period of time, blind. So we call it, just a jargon, just a blindness disease. So the medication had some effect on that virus. So it was just, I would say, a coincidence. And we didn't have even to use it because the transmission at global, let's say between continents, was minimal, was not even existent. So that's how SARS ended. And I mean, it was, I would say technically it was a big surprise because we were all worried about it, but it didn't at the same expansion and speed. Of course, things have changed, but not to that extent. I mean, because now we have COVID-19 everywhere. Even those who pretending that they don't have it, there are countries pretending as we speak that they don't have anything like that, but it's not true because it's everywhere. Because I mean, people say, okay, communication, which is important, mean that we are traveling in big numbers from one set of countries or group of countries to another one. I think it was a matter of luck. I can tell you if I can, yeah, I can use that. If you accept me, accept it I mean, I would say the main idea we come up at the end of SARS is that okay, we're just lucky. So the word is just lucky.
Thank you. Maybe we'll go to the next question.
Sure. The next question is, please elaborate on the demographics such as ethnicity and gender of the participants in the clinical trials of Pfizer and Moderna, and how much does the composition affect efficacy in the real world?
I think that's for you again, Dr. Kamwa.
Okay, thank you. No, I don't have the numbers. I didn't know that we'll be at that level. But usually, we try to make sure that there is no discrimination. With the beginning is okay. What is the size of the target population? So what is the size? What's the gender? And from there, they build I would say the group to start with. I think that's the not the easiest way, but that's the way which is done for in many instances. Of course, there are some instances where I mean, you have to accept you join. Not it's not I don't have a group of. I have a target in terms of numbers, but then you start recruiting those who are exposed. And at times, you also have in some laboratories have to do what they can to attract. If there is, let's say, a gender imbalance, which is so great that okay, this could raise some questions, so they have to attract, the other gender in the study. That's what I can say. I don't have the numbers, but I could have, if I knew that the question would be asked, I could have checked and get some numbers.
I think it's fair to say it's publicly available. I did see the Moderna breakdown, and that you could see that the breakdown, at least by race and ethnicity, was similar to the breakdown in the U.S. population in terms of the participants. But I think it's an excellent question, and I think it is publicly available, and we can try to point people to those resources.
Great. There was one attendee who had asked a question around the Tuskegee syphilis study in terms of the impact on trust in the community. And then, of course, Cheryl addressed that, and that same attendee said, thank you, Adaoma and Cheryl, for keeping it real. I think that question's been addressed. There is a question here around, do we have a sense of what percentage of our Northwestern Toronto community get the flu vaccine each year? And is there a way to leverage that group as it relates to the COVID vaccine?
I mean, I don't have the numbers, but the link with flu vaccine is not. I mean, I would say that we can relate it to the flu vaccines. As we know, the vaccine is not flu vaccines. I would say plural because at times they have many. We have many. The flu keep on changing every year, and the virus keep on changing every year, meaning that every single year, uh, uh, manufacturers have to wait to know, say the virus of the year at the beginning of the year before proceeding with production of the vaccine, which is different from the vaccine used the previous year. That's I would say dilemma with flu vaccine. It's not the same. It's not the same problem each year. It differs. It change. I would say keeps on changing for years. And when let's say you are a manufacturer, you have you have a reserve from your production of previous year. Yeah, you can put it on the market if it's the same virus or similar virus. Otherwise, you have to start production change again for the year. So there's a big difference between I would say the flu we know, the seasonal flu, and what we have as COVID-19. If I got the question very well.
I would like to add to that. I mean, we do collect these statistics, and we do know that within the community sector anyway, there is a fairly high uptake. I would say somewhere between 60 to 70%, which is, I think, high for the flu vaccines annually. And again, because we target the vaccines to, the seniors and those with underlying conditions, I think there's much more. And the fact that they've been around for such a long time, there's been increasing trust and uptake of that vaccine.
Thank you.
Thanks so much, Cheryl.
Cheryl, there's a secondary question to that, the percentage of vaccinations taken by racialized communities. Someone's asking, where can we see those statistics? I don't know if you can point anybody to where you'd see those statistics.
I think, unfortunately, we are not very good at collecting race-based data when it comes to these things. So this is something that we have to work on. We don't have data on that. I think I could confidently say, but it is something that we've been pushing for because we do know that we have to have use the data to have targeted interventions to ensure that our communities are protected as well as possible.
Right. There's a question here. I think this was based on something that Dr. Kamwa said. It said, you mentioned the color of the skin, which may make the vaccine act differently. Do we know what were the results of countries with darker skin tones?
That's a that's a difficult question. I don't have data per se, but again, we are still I would say at the early stage. So, and maybe in the weeks or the month ahead of us, it will be possible to have additional information.
I think that's similar to the trials where we had participation by people from different countries and different racial and ethnic backgrounds, and I think the safety and efficacy is the same. I think the impact of COVID and the relationship between the social determinants of health, which we've all talked about in this panel, is a different story than any kind of genetic difference.
The next question, based on negative side effects, can the vaccine be changed over time?
I mean, so far, I mean, it's too early to know whether we know that the COVID-19 is also it's a kind of flu virus. So, but we don't know. I mean, it's too early, but to know that, okay, the virus will be evolving. In fact, our hope is that we don't have the virus in circulation in the next few months.
Yeah, I think it's also fair to say that with the rollout, which is the final stage of the vaccine, is when it's been approved and it's safe and efficacious, and it's being actually administered. The monitoring continues, and so in every jurisdiction, any kind of side effects or adverse events continue to be monitored. And I think what we've heard as people take, particularly their second dose of the initial vaccines, is that you may feel a sense of fever or some sense of illness, which is your body reacting to the instructions that the vaccine give. But I think really important to know that the province, just like every jurisdiction, are closely monitoring any kind of side effects or adverse events.
Okay, so maybe the last question is around, given the history that everyone has spoken about with a community, how does that shape community engagement moving forward when trying to communicate with a community about the vaccine?
Would like to take that question. Can I ask Adaoma or Cheryl?
Sure, I can start, and then Cheryl, you can jump in. So we've learned that there are different ways to engage with the community. In the past year or since the pandemic hit, we've been forced, we as in the systems, have really been forced to engage in new ways. Some of those sort of individual interactions, the on-the-ground work that Black Creek and other community health services are providing, where residents are playing a leadership role, where we are continuing to have the dialogue and discussion, not just in sort of academic or healthcare spaces, but within faith organizations, within local community and grassroots organizations. And the willingness for healthcare providers, those in policy and decision making, to interface and interact with residents. I think it hasn't happened on this scale before, and so we need to again think about what are those things we want to continue going forward. What are the things we kind of want to throw out that didn't work before? And I think it's really critical that forums like this, we sort of propel and increase the number of these that we're having, reaching different segments of the African, Caribbean, and Black communities, being able to address specific concerns, because of course we're not a monolith, and there are differences and perspectives on the role of vaccine. So we need to build on the work that we have begun, making residents center of that work, taking up the leadership, and then sort of wrapping them around them with faith organizations and community.
Thanks so much.
And I could just add to that, Adaoma, you've said it all. I think it's really important as we move forward and we reflect, I think, on lessons learned throughout this pandemic, is to really ensure that we involve patients and community members in co-design even of interventions. And the most immediate one is the vaccine rollout, and not necessary, and really validate the experiences of the community, the thoughts and concerns of the community. we know that people have questions, and those questions are not silly questions. They're real questions, and we need to answer them, and we have to respect where they're coming from, the places they're coming from. We have to educate ourselves as well as to why these questions are coming to us, and why, as we've discussed here today in this forum, where some of the distrust is coming from, the history of different people in our community, and really involve them in our planning and conversations. And I know that we've begun to do that. We all within our organizations have patient advisors or client advisors, and I think within our OHT, the Ontario Health Team in Northwestern Toronto, we're talking about this, and we're trying to figure out better ways of including different voices in our planning moving forward, because we have other things as well to address. We have other health issues and other concerns that we want to improve on in our service delivery. So it really is just a matter of remembering that community voice and how important they are. And I think Dr. Kamwa said that earlier, just remembering that everyone has an equal right to quality care, to care in general.
Very well said. Thank you, Cheryl. And I think important to recognize that these conversations are going on all over the city now, to think about how we can work with communities and organizations like Jamaican Canadian Association, Black Creek, Black North Initiative, the Black Physicians Association of Ontario, all trying to address this issue of addressing racism in healthcare, addressing trust issues, and then also trying to make sure that we don't leave any community behind. I think we'll go now to our final poll, and we'll see if we've seen any difference between the beginning of our conversation. And this again will be below the streaming video.
So the poll results are coming in, and it looks like there has been some movement. So I'm going to say around 84% would take the vaccine, and about 16% are sort of on the fence, but nobody would not take the vaccine. So we have moved.
Wow. Wow, kudos to our panel. That's fantastic. It shows the power of these conversations, and a big thanks to Humber River and to our panelists for hosting this. So I'm going to turn it back to Barb.
Great. Thank you very much to all of you. I just want to take 1 second and answer the diversity question that came up. I have this in a slide that I use sometimes. So actually, for the Pfizer drug, the most common of them, about 46,300 participants at 153 different clinical trial sites around the world. Trial sites were located in Argentina, in Brazil, in Germany, Turkey, South Africa, and the United States. And of the participant diversity, they say approximately 42% in the overall study participants had a diverse background. 5% Asian, 10% Black, 26% Hispanic or Latin, and 1% Native American. And then they talk about the age, and the 18 to 55 and 56 plus were the largest number of the ages. So I just thought I would share that since the question came up. And then I just want to thank all of our panelists and our moderator for sharing your perspectives this afternoon and for the information you gave us. Your messages were pointed, and we really have a lot to reflect on. I think particularly around messaging, access, equity, collaboration, and that this is not a one-time event. It's a much broader perspective than that. So I thank you for that information. And I wish to thank you for facilitating the panel presentation. You did a wonderful job. You kept us on time. We hope you'll take the information back to the province. And in your new role, we look forward to working together on promoting the vaccine issue using an equity lens, but on promoting the health needs of our community and of the Black communities in Ontario. Thank you to our organizers who worked hard to make the event happen. Most of all, thank you to our audience for coming out and participating in our Black History Month celebration, and for joining us in this discussion and for being so thoughtful. In terms of next steps, Cheryl and I, who co-chair our Northwest Toronto OHT, will take the feedback from our conversation back to the team as we begin to plan not only for vaccines, but for the health and recovery of our community. Stay tuned for more information about vaccines in our community, which we will share through our organization's website, as well as with our Northwest Toronto OHT partners. And Cheryl, as the co-chair of the Northwest OHT, I just wanted to see if you had anything you wanted to add.
Thanks, Barb. I think this was an amazing conversation, and I'm happy that we put it together and we were able to do this as a team. The tagline of "We're in this together," was born with the COVID pandemic, and we truly are in this together. And I don't think we can do it individually. We can't solve these problems individually. They're big problems, complex problems. And I think, please, I to the audience, to the community members in the audience, I want us all to work together. We need to build some trust, but we are here because we care, and we really want to work together to ensure that our community has the best care ever than anywhere else in the province.
You're right. Thank you, Cheryl. So to all of you, have a good afternoon. Thank you so much for joining us.